at 40 years of age. Mean time from the PAO to the total hip was almost 8 years, range 2 to 15. The majority, 81%, were female patients, average BMI 28. These are data from surgery. Most importantly, reasonable operative times. Posterior approach was far more common in this cohort of patients. This may have changed over time. 100% of the acetabular components were cementless. We did cement 5% of the femoral implants. The most common femoral stem geometry was a wedge taper design. The majority of the patients had a polyethylene with either cobalt chrome or ceramic femoral head. There were 6% of the hips that had a ceramic on ceramic bearing, and about 3% of the hips with a dual mobility bearing. Looking at radiographic cup position, our average abduction angle was 41. Anteversion was slightly high at 28. Follow-up on average was 5 years, ranged from 1 to 20. We noticed marked improvements in the modified Harris-Hip score from a starting score of 50 to a final score of 87, indicating a 37-point improvement post-operatively. Here is a list of our complications. So all of these complications required either hospital admission or surgery. So overall, 6% complication rate in these total hip arthroplasty procedures. Our Kaplan-Meier survivorship curves indicated a 96% survivorship at 5, 10, and 15 years. This is the Kaplan-Meier survivorship curve, indicating some early failures in that first 5 years, and then after 5 years, we have a steady survivorship with no changes over time. In terms of the existing literature, we have several studies in the literature as listed here: Parvizi et al., Duncan, Amantula, and then Osawa, and starting in 2004, going to 2016. The outcomes of these papers are somewhat distinct, but the general themes are that the clinical outcomes and survivorship of total hip arthroplasty after periacetabular osteotomy are comparable to patients that have not had a previous osteotomy. Nevertheless, one study did note that the implant positioning was not as accurate in the setting of a previous PAO. A couple of the studies also indicated that the surgical procedure may be slightly longer and associated with a higher blood loss. Real important take-home message from these studies is that a well-done osteotomy facilitates subsequent total hip and probably has little or no impact on the clinical outcome and survivorship. Most important is to assess the acetabular anatomy preoperatively. Early on in the PAO experience, retroversion of the acetabulum was common, and we certainly want to adjust to malpositioning of the acetabulum at the time of total hip arthroplasty. This is a case example showing a PAO. This PAO was done at an outside institution. The acetabulum is overcorrected, so we have major anterior lateral overcorrection of the acetabulum with acetabular retroversion after the PAO. So when we go on to do our total hip arthroplasty, we have to be attentive to this underlying malalignment of the acetabulum, and we have to adjust accordingly. So on the top right, you see our preoperative radiograph prior to total hip. The osteotomy is healed, but is malpositioned. Below that, we have the total hip arthroplasty with implants in good position. If you look at the intraoperative picture in the middle of the slide at the top, you see we've placed the acetabular component independent of the native anatomy of the acetabulum. So here we're looking from posterior at the anterior lateral acetabular rim, and you can see the anterior lateral rim is prominent by at least 1.5 centimeters above the well-positioned acetabular component. So we're going to be careful to place the acetabular component independent of the distorted anatomy, and then we have to adjust accordingly. So on the second intraoperative panel there, you see taking down of that anterolateral acetabular rim with a half-inch osteotome to remove potential for impingement of our total hip arthroplasty. So we did a rim resection, placement of the acetabular component in the appropriate position, rim resection to relieve impingement associated with a good outcome. This is a case of mine. This is a complicated dysplasia. I just have the left hip preoperatively here, but you see this is a very active, athletic young male. He has significant dysplasia. He has major femoral head cystic changes. Given his young age, we did do bilateral periacetabular osteotomies and recontouring of the head-neck junction with osteoplasty. Here he is in 2005 after those procedures in hips that we know are somewhat tricky in terms of the cystic lesion of the femoral head and potential for secondary impingement. He had an excellent outcome with this and went several years. He finished his collegiate baseball career. He then went on to coaching baseball. He then presented 18 years after his PAO with worsening pain. These are those radiographs. So now he's on the left, he's 18 years out from his PAO. He was actually very satisfied with the clinical outcome and the fact that he could return and complete his collegiate athletic career. This year, he underwent bilateral stage total hip arthroplasties as shown on the right. Really, in these hips, pretty straightforward. We don't have a malposition problem of the acetabulum and a pretty straightforward total hip after the PAO. Expectation for these hips is to be the same as a total hip arthroplasty performed without a previous PAO. Limitations of the study, all these cases were performed by experienced surgeons who do both PAOs and total hips, so there's obviously sophisticated understanding of the procedures and not clear how generalizable the information is. It is a retrospective cohort without a control group, so we're just almost assuming that we're having comparable results to patients who have not had a previous PAO, but certainly the data supports that. And then the data collection process might not be perfect. 3 separate institutions may introduce some variability in the data collection. So in conclusion, THA after PAO is clinically effective. It's the survivorship is satisfactory of 96% at 5, 10, and 15 years. There's an acceptable complication risk of 6%. And the most important is we want to place that acetabulum carefully, understand the anatomy preoperatively, and make sure we avoid retroversion of the acetabular component. That was something described earlier in the experience with doing total hip arthroplasty after the PAO. In our series, we actually tended to have a slightly higher anteversion in these hips, perhaps because we are aware of this potential retroversion issue. Thank you for your attention. I hope it's been a great meeting.